This is one of those trials that I've seen all over the place, literally at the ACC, at ESC, and now coming to a JACC near you, December 9th issue. There is a pair of papers and an editorial comment talking about the TRE-2P, or TRE Secondary Prevention, TIMI 50 study, and I, with Marc Bonaca, who is from Brigham and Women's Hospital and a TIMI investigator. This has been around for a while, and I had to learn from you how to pronounce this thing. So it's the TRE-2P, or Secondary Prevention Trial, or TIMI 50. When did it begin? It was like Tracer, right? Was that the beginning?
Yeah, so there was a large body of early clinical and preclinical work looking at PAR1, which is the primary receptor for thrombin on platelets, and a thrombin receptor antagonist called Vorapaxar. And this was launched into a large clinical program of phase 3 trials, almost 40,000 patients. One was investigating Vorapaxar in the acute coronary syndrome, and that was the Tracer trial. And then there was a large trial called TRE-2P TIMI 50, which investigated it for long-term secondary prevention. And this was in a very broad population, patients who enrolled with a history of ischemic stroke, those with a history of myocardial infarction, and those with symptomatic PAD. So it's actually been investigated in a broad spectrum of patients, and that's why you've heard a lot about it.
Now, this pair of papers in JACC is on the TRA secondary prevention, correct?
Yes.
Okay, what's the first one about?
So the first one, so there's two papers. The first one is looking at an endpoint of coronary stent thrombosis, and I think that's something that's very much on people's minds. It has been, especially in the era of drug-eluting stents. Right. There was data almost a decade ago suggesting that there was a risk of very late stent thrombosis from observational data. Until recently, there were really a series of smaller trials that said, well, maybe with newer generation stents, we could go with shorter durations of dual antiplatelet therapy. And of course, at this ACC, we've learned a lot about that. So we found similar results that in a long-term secondary prevention population over years, there is an ongoing risk of late stent thrombosis across a variety of stent types. And this really, if you look at the risk, it's linear. It doesn't drop off after a year or 2 years. So that was one of our findings, that similar to DAPT, there is an ongoing risk of very late stent thrombosis, so stent thrombosis occurring after a year in patients who have a history of stenting. The second part that we looked at is PAR1 antagonism an effective target to modify this endpoint? Does blocking PAR1 reduce the risk of stent thrombosis? And we found in TRE-2P TIMI 50 that it was, that patients that were randomized to Vorapaxar had a significant reduction of about 30% in stent thrombosis overall, and that was in addition to aspirin and clopidogrel or aspirin alone. There was no heterogeneity, so that on top of an ADP receptor blocker, or at least clopidogrel in this study, or aspirin, there was an additional 30% reduction with Vorapaxar.
Now this was an or, not an and, in terms of aspirin.
No, it was you could be on both, or you could be on aspirin alone, and actually a large proportion of the patients were on both.
How do these two trials now come together in a clinical scenario?
I think it's a great question. I think there are two robust data sets now, and of course this was the primary question of DAPT, is what is the long-term risk of late stent thrombosis? And I think that we have seen clearly now in well-powered trials that there is an ongoing risk. I think in DAPT there was a demonstration that the addition of clopidogrel or an ADP receptor blocker could further reduce that risk. And then in TRE-2P TIMI 50 we've shown that a PAR1 antagonist, in addition to that, can further reduce the risk. Of course, when you integrate all this in terms of clinical decision making, you have to think of the risks and benefits, and all of these antithrombotics increase the risk of bleeding. Stent thrombosis is a rare event, and so I think biologically these observations are very important. How they are integrated into clinical practice are a different question. So Vorapaxar is approved for patients with a history of myocardial infarction, and these data at least suggest that there's a benefit for those that have a stent in terms of reducing stent thrombosis. So I do think that there are patients that will benefit from this therapy, and I think it's up to clinicians to decide who are those highest risk patients. Maybe they're diabetics. We saw what looked like a trend for very favorable benefit for diabetics. Maybe those with complex stents that can derive additional benefit from this therapy.
And low risk for bleeding?
Yeah, and certainly, of course, so you have to think about risk of bleeding. I think the primary factor is if the patient has had a history of stroke or TIA, the drug Vorapaxar is contraindicated. But for those that are at a relatively low risk of bleeding, there's benefit there.
So are you going to do anything else after this? I mean, this has gone on for ages. I've been reading and writing about this particular trial. What's next for you?
We're looking at a lot of things. I mean, there are a lot of questions still that remain. There's an analysis looking at the benefit of Vorapaxar with and without dual antiplatelet therapy. It was added. It was a sort of triple therapy for some patients, a double for some. And there's actually a manuscript by Dr. Bahula now that we're looking at, and I think that will add additional information. We're looking at calculators of risk and benefit, so helping clinicians decide who should get drugs in terms of the optimal net benefit. And then we're also looking at some of the other endpoints, for example, PAD events, limb events, and further characterizing those. So there's a lot of exciting work to come.
I mean, out of this meeting, do you think, for a while, dual antiplatelet therapy was absolutely where you wanted to go, and then you wanted to do it as long as humanly possible. Then they started thinking, well, heck, if we back off this, we can do just as well. Now it's looking like there is a question as to whether that triple therapy, for God's sakes, for a while there seemed to be like, no way is triple therapy going to actually take over. It's just too high risk, too high bleeding. Where are we now, and particularly after this meeting?
Yeah, so I think it's a great question. And I think when you look at DAPT, it really was looking at two questions. One was, when do you stop dual antiplatelet therapy for somebody who receives a stent? But the second part of that, and I think particularly telling, is that there's an element of secondary prevention. There's a group of patients within that trial that had a history of MI. And I think when you take the TRA2P experience, you take DAPT, and then Pegasus will be reported next year, which is looking at long-term secondary prevention after MI, and hopefully the results will be consistent. I think there is a message here that patients who are at risk of spontaneous MI, patients who have real coronary disease, who have had an atherothrombotic event, they do benefit from long-term secondary prevention with multi-agent antiplatelet therapy. The next question is, what is the optimal cocktail of agents, right? And I think that is a far more complex question, and will be the subject of a lot of debate. We'll have to see what the Pegasus results show. But I think there are pros and cons for all of these agents.
Well, Dr. Bonaca's work, as I said, it's a pair of papers, plus there is an editorial comment, and this is in the December 9th issue of JACC. Please look those up. For Cardio Source World News, I'm Executive Editor Rick McGuire.